Correct. I चालू होने देख लो, मैं चलती रहेगी। ये वाला ये तो चल रहा है, चेक किया था। हमको दिन में नहीं किया तो अगर है ऐसा नंबर के बोलेंगे तो मेरे इधर होने से क्या लगा? तेरे को मैं टीवी पर चालू करने से रोक रहा हूँ, तेरे को कुछ करने से रोक रहा हूँ। नहीं चाहिए तो मैं नहीं आऊँ तो मेरे को फोन क्यों कर रही है? बाद में देख के सिर्फ मैसेज करता हूँ। मीटिंग में हूँ, मेरा लेक्चर चल रहा है। देखो डॉक्टर प्रेजेंट ओवर टू यू, ओवर एंड आउट। मैं तो कुछ नहीं कहूंगा यार, होगी नहीं।
तू क्या खाएगी? जो तू खा रही है वो मेरे भी बना।
Hello, who is answering today?
Sir, good evening, sir. I am Dr. Rahul. I am answering, sir.
Rahul. Who else is there? Rahul, apart from you?
Sir, I don't have any idea, sir.
Good evening, sir. Dr. Anand here from Jaslo.
Okay. Anand is there. Rahul is there.
Yes, sir.
Then Namisha is there. Anyone else? Okay, so Anand and Rahul.
Yes, sir.
हेलो हेलो
Hello, कौन?
गुड इवनिंग सर स्वप्निल आई एम फ्रॉम जसलोक आई एम आल्सो आंसरिंग
Swapnil. Huh?
यस सर
Okay, fine. So we'll just start in another 5 minutes. I'm just waiting for Dr. Gite to join. Okay, and today we are going to discuss 3 cases, mainly like a short cases, and they are all complicated urolithiasis, continuation of the last time. So we will not go too much in the history because last time we have discussed about that, but still history in short, examination in short, and mainly the management so that you can answer well in your exams.
Microphone is open.
Hello. Hello.
Hello.
Oh,
Can I think we should start now. Dr. Gite? So we start, but who again, just tell me who are all answering.
Sir, I am Rahul. I am from Institute of Urology, Dhule. I am answering today, sir.
So Rahul is answering, Anand is answering, correct?
Yes, sir.
Just look.
And Swapnil.
And
Traumatic acoustic.
Yes.
Swapnil,
Traumatic
Swapnil, you have joined as an iPad?
Yes, sir. I changed my name.
Okay, then we will unmute others.
Yes.
Okay, I think we should start now. Brijesh?
yes, sir. A 73-year-old male patient presented with complaint of one episode of pain over left leg 10 days back and fevers and chills along with increased frequency of urine since 7 days. Am I audible, sir?
Yeah.
Yeah.
Please, and others, please unmute yourself. Okay, so Swapnil is answering, Rahul is answering, and
Anand.
Anand. Okay, so Anand. So this is a short history. Just tell us what are the important questions you want to ask, and then we'll go ahead.
Sir, I would like to elicit the symptoms more, sir. Pain, whether it is continuous or colic in nature, and fever and chills. I would like to elicit more about the symptoms.
Okay. And anything else you want to know? No, just tell us what are the positive history you want to ask, and he will tell you everything. See, Rahul, when you hear this, that patient has got a pain in the left flank, and he has got fever with chills and rigors, and he has increased frequency of urine. Now, what are the probable diagnoses that comes into your mind? If you are sitting in your OPD,
sir,
yeah.
73-year-old male patient with one episode of pain over left flank since 10 day history of 10 days back and fever with chills. The first differential diagnosis in my mind is, sir, infective or inflammatory etiology. Then, sir, stone disease. Then, sir, renal cystic disease. Then, sir, at the last, I would like to keep as a renal cell carcinoma or any malignancy and tuberculosis.
Tuberculosis.
See, this is very simple. Patient has got three important problems. Correct? First is a pain in the left flank. So that is some obstructive in the left urinary system. Second thing, patient has got fever and chill. That means he has got infection. And the third, he has got a frequency of urination. So basically, there is a irritative or a storage problem.
Yes.
So there may be a couple of pathology which can give rise to this problem, or there may be a combination of two pathologies, right?
Yes.
Yes.
So there is an obstruction and there is an infection. So what are the causes of obstruction? One is a stone.
Yes, sir.
Yes, sir. Sir,
Second
then
thing can be
ureteric stone, sir.
Okay.
Sir,
Second,
ureteric stone, sir, at
yes,
VUJ. Yeah,
exactly.
such kind of
Right.
presentation is common in this. VUJ is for irritation of bladder.
Yeah.
Frequency also.
Yeah. Or second, it can be two pathology. Like he might be having prostate problem also, and he might be because he's 72 years old, and he might be having obstruction with infection. Okay, so keeping this in mind, now you ask the further question. Okay, Bridget, just tell them what is the history.
So patient was asymptomatic before 10 days. Then he developed a single episode of pain in the left flank region. Pain was colic in nature, radiating from loin to groin, radio taking analgesics, no specific aggravating factors.
Yeah, go ahead.
Fever was high grade with chills, for which patient got admitted in nearby nursing home and was treated with IV fluids, analgesics, and antibiotics and responded well to the treatment.
Who is presenting the case today? Good evening.
Good evening.
Good evening, sir.
Our resident is presenting, and
Hello.
answer is Brijesh is our resident who is presenting this case, and Rahul, Anand, and Swapnil, three are answering.
Rahul, are you able to listen? Hear me?
Yes, sir. Yes, sir. I am able to hear you. Good evening, sir.
Yeah. Dr. Gite.
Yes, sir. So it's
Yeah,
it's
so-
9:10. We will start, sir. People will join slowly.
Yeah, we already started.
So I'm not able to hear first few minutes.
Okay. Again, Brijesh,
Yes, sir.
start the history and let the Dr. Gite hear about it.
So 73-year-old male presented with a complaint of one episode of pain over left flank region 10 days back, and he had a complain of fevers and chills along with increased frequency since 7 days.
Go ahead, Bridget.
Yes, sir.
Just go ahead.
Yes. Fever was high grade associated with chills, for which patient got treated with IV analgesic antibiotics nearby nursing home and was responded well to the treatment.
Make
Hello.
all other people mute except the person who is answering.
మా ఫ్రెండ్ అక్కడ చాలా మంది ఉంటారు మా ఇంటర్మీడియట్
Hello.
Make all other people mute, please.
Reddy, the host, please make everyone mute.
మా ఫ్రెండ్
Except the person who is answering. 1 plus IV 2201. Who is 1 plus IV 2201? Please make himself mute. Pankaj Chavan, please make yourself mute, please.
So we request all of you to keep yourself mute, okay? Except those who are answering. Thank you. Okay. Fine.
So Rahul,
Okay.
this is the complaint of the patient, which is
Yes,
come to your OPD and sitting in front of you. So what are the things you will see,
Yes, sir.
ask?
Sir, I would like to ask about the pain, onset, duration, and progress of pain. And sir, nature of the pain, whether it is colic in nature or dull aching nature, severity of the pain, mild, moderate, severe nature, number of episodes of the pain, whether pain is associated with fevers, chills, whether it is associated with nausea, vomiting, any aggravating or relieving factor of the pain. And yes, sir, this is about the pain I would like to ask. And he had already taken a treatment in the nursing home. I would like to know which treatment he has taken, which antibiotic, which analgesics he is taken. And sir, I would like to know all these details about the patient.
Any negative history you want to ask?
Yes, sir. I would like to know whether patient is having any hematuria, any history of lithuria, any history of lower urinary tract symptoms, any history of bilateral lower leg swelling or puffiness of the face. Then, sir, I would like to know any constitutional symptoms of the patient, any history of the recent endoscopic procedure done. Sir, I would like to ask all these negative history to the patients.
Okay, when you are asking the negative history, there should be some diagnosis in your mind. At least 2-3 diagnoses after listening the complaint and elaborating the complaints. And you have to rule out the probable diagnosis by asking the negative histories, like and their complication also. So negative history pertaining to ruling out the diagnosis, differential diagnosis, and pertaining to related to the complications and associated symptoms of that particular disease, what you are expecting in your mind. So that should go in one line. For example, if it is a renal failure, so puffiness of the face, vomiting, nausea, swelling all over the body, weakness. This if you say in one line, examiner will understand you are ruling out the CRF or renal failure. So if you ask frequency, urgency, past history of tuberculosis, and then the dysuria, pulmonary symptoms, in that you are asking in one symptomatology for that particular tuberculosis. So it should be like that. In spite of telling one symptom from that this disease, another symptoms from that disease. So you make a habit.
Yes.
While asking the negative history, suppose this is a 70-year-old male, and I put short duration 8 to 10 days pain associated with fever and chills. So we don't know about his past, and he has taken some recent treatment. So usually in such history, is present in what are the probable things should come in anybody's mind. So considering the age,
Sir, yes,
so it may be a stone
sir,
disease.
Stone disease.
It may be a
stone
cystic
disease,
disease
any
which got
infection,
infected.
inflammatory.
It may be a complex cyst or simple cyst which got infected. It may be a PUJ. It may be associated with probably maybe tuberculosis down the line. तो ये सब चीजें दिमाग में रखना है और वो हिसाब से उसको हिस्ट्री पूछना है.
Yes.
Okay. So go ahead. Who is
No
presenting
history
the
of
case? Please go ahead.
hematuria, no any history of catheterization or instrumentation, no facial puffiness, breathlessness, excession or bilateral edema, no bleeding disorders, or patient is not on any anticoagulant therapy or blood transfusion. The patient is known case of diabetes and is maintaining on injection regular insulin 10-10-8 units, no allergies, family history is nothing significant, bladder increased frequency and nocturia, sleep is disturbed due to increased frequency and nocturia. No any addiction, non-smoker, non-alcoholic.
Fine. So now this is the history. Anything else you want to ask? Anand? Rahul, anything to ask? Otherwise, we'll go ahead.
Sir, sir, duration of the diabetes and sir, since how many years or days he is taking insulin and his sugar control.
So he was diabetic since 12 years. Previously, before 5 years, he was taking oral hypoglycemic agents, and from last 3 years now he is maintaining a regular insulin.
So considering his age, I am interested in ruling out other lower urinary tract symptoms also.
Yes.
Number one. Number two, now here is a diabetes. So again, one more point, diabetic, fever with chills and pain. So it is directing towards some particular disease. Slowly it is going towards one particular disease. So in this, I am interested in what treatment he has taken in that nursing home. Is it surgical treatment, medical treatment, injectable, tablets, or how many days, how many times? ये सब चीजें अगर पॉसिबल है तो वो भी I want to make it clear. And कुछ रिपोर्ट्स है तो वो रिपोर्ट भी मैं देखना चाहूंगा वो हॉस्पिटल, so that there may be some clues in making my diagnosis. If not available, it's okay. ये ऐसा clear exam में भी बोलना है.
Yes.
So that the examiner will know you are thinking in a broad way and you are thinking in all the aspect of that particular patient's complaint.
Yes.
Okay, next.
We just go ahead.
Yes.
Sir, I will.
Yeah.
Several examination was normal. Pulse, blood
Rahul,
pressure,
1 minute. Let us ask Rahul. What are the things you want to know now?
Sir, I would like to do general examination of the patient, and after the general examination, I would like to proceed for systemic examination of the patient.
Okay. So Anand, what are the things you are expecting? Who else is answering? Rahul?
Swapnil.
Swapnil is there. Swapnil and Anand also.
Yes, sir.
So Anand, can you hear me?
Yes, sir.
Okay, Anand. So now what are the things you are expecting in general examination and anything specific?
Sir, renal angle tenderness.
Rahul, Anand.
Yes, sir.
Here we are expecting some stone related disease, and that patient has a diabetes, that patient has a fever and chills. So go systematically in general examination. What I am going to see, समझो for example पेलर है, facial edema है, facial puffiness है, और फिर और कुछ जनरल एग्जामिनेशन में कोई जनरल साइंस है क्या, जैसे कि फॉर एग्जांपल रेनल फेलियर, डायबिटिक नेफ्रोपैथी की वजह से कुछ साइंस मिलेंगे क्या, उसके बाद में फिर लोकल एग्जामिनेशन में, एब्डोमिनल एग्जामिनेशन में टेनल एंगल पे 3 चीजें देखना है, फुलनेस है, टेंडरनेस है, या फिर लोकल स्किन के कुछ चेंजेस है, इरिथमा है, एडिमा है, ये कुछ रेनल एंगल में मिलता है क्या, पाल्पेबल किडनी है क्या, ओल्ड मैन है तो पाल्पेबल ब्लैडर है क्या, पोस्ट वाइड रेसिड्यू अगर हो सकता है, इसमें ज्यादा रह सकता है। तो ये सब चीजें एक 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 जैसा तुम लिखते हो वैसा अगर बताते चले गए तो इट विल बी इजी फॉर यू एज वेल एज इजी फॉर एग्जामिनर, यू आर थिंकिंग in a right direction.
Yes.
Okay, go ahead.
Yeah, on general examination, everything was normal. Patient was cases cooperative, well triplation person, no evidence of any pallor, cyanosis, or clubbing. Head to toe examination was grossly normal. Pulse and blood pressure were within normal range. Local examination, patient was examined in supine position. External genitalia were normal. Only right inguinal hernia was present. On abdominal examination with implant consent, exposure of nipple to knee, adequate light, everything was normal. No renal angle tenderness or anything. A right inguinal hernia can be palpated and can also be visualized. Normal auscultation and normal breath sounds. Rectal examination done in Sims position, normal element tone, no fissure, no fistula, grade 1 prostatic enlargement, form inconsistent, non-tender, rectal mucosa mobile, no blood on gloves, rectum empty.
Fine. So Rahul, Anand, and Swapnil.
Sir,
This is the examination. Now, okay, Rahul, you say.
Sir,
Now, what else you want to do?
sir, two things is missed in the focal neurological examination. Always बोलना है. That is one.
Yes, sir.
Another explanation given about the hernia, that is insufficient. So hernia hydrocele is a part of urology also. Okay. So you should be in detail कि inspection में वो swelling है कि नहीं है, वो कौन से साइज की है, reducible है नहीं है, का पिंपल्स है नहीं है, फिर पाल्पेशन में तो 2-4 चीजें जो हर्निया के फिंगर इन्वेस्टिगेशन टेस्ट का पिंपल, ये सब चीजें उसमें बोलना है. उसने उस एग्जामिनर अगर बोला कि लीव दैट हर्निया असाइड, ऐसा अगर बोल दिया तो वो है, लेकिन बोलते समय वो पूरा का पूरा हर्निया का जो फिक्स पैटर्न है तो पूरा बोलना है. Okay, so this is all about the examination. So what we expect? The complaint पता है, local में कुछ मिला नहीं है, और general examination में खास कुछ नहीं है, except patient may be febrile considering his fever.
Yes. Sir, depending, sir, patient is 70-year-old with flank pain and history of fever with chills. Sir, I would like to keep my differential diagnosis stone disease as a first diagnosis. After that, sir, infection or inflammatory pathologies as a second diagnosis I would like to keep. Then, sir,
inflammatory pathology means what?
Sir, infection.
It is a very vague terminology. Inflammatory pathology of prostate, bladder, kidney, ureter, any disease, what you are thinking. ये clear बोलना है. First diagnosis you told कि stone disease which got obstructed and converted into
urinary tract infection. Yes. Then, sir,
infection, that is one pathology.
Then, sir, cystic disease may be possible. It is simple or complicated cystic disease. Then, sir, pelviureter junction obstruction. Then, sir, as history, as age consideration of age, I would like to keep as a renal malignancy down as a my diagnosis with
which renal malignancy will present as a pain, fever, chills?
Sir, as such, pain, fever, only pain, fever,
fever,
renal angle tenderness. Sir, malignancy will not present like this, sir.
Then why you are creating problem for yourself? So tell the diagnosis which is related to the infection.
Yes,
first is stone obstruction, diabetes, may be
diabetic.
associated with emphysematous pyelonephritis या non-complicated pyelonephritis, ये कुछ भी रह सकता है. That is one thing.
stone and obstruction with diabetes, with plus minus emphysematous or non-complicated pyelonephritis. That is one thing. Another thing, cyst and infection. Simple cyst, complex cyst, multiple cyst, what infected, cyst and infection. Another thing, PUJ and infection. So there should be some pathology, obstruction and infection. These are the possibilities you have to tell initially 1, 2, 3, 4. Associated pathology diabetes है, emphysematous pyelonephritis रह सकता है, renal papillary necrosis रह सकता है, cleftoid papilla and blockage of the urate fan again back infection and same presentation. तो ये अगर तुमने 4-5 पहले बोल दिया ना तो वह अननेसेसरी गलत तरीके के तरफ नहीं जाएगा.
Yes.
So, Anand, I want to ask you one question. Tell me the two different things, two pathology, which will give rise to obstruction and infection in diabetes.
Sir, papillary necrosis, sir, causing obstruction.
Very good.
There were obstruction of papilla causing obstruction to a ureter, and it was pain. Similar kind of presentation.
And second is the stone. So all other things are, you may be seeing, but in your 3 years of residency, I'm sure you must have seen maximum is stone obstruction with a infection, and second is a papillary necrosis.
Yes, sir.
Correct? Many a times patient is admitted in ICU and you get a call, and then when you do CT and there is a PET, there is a spending and it is showing mild hydronephrosis, septicemia or the count is very high, and that is the time when you diagnose that most probably he has got a papillary necrosis. Correct?
Yes.
So in exam also you think the same way. Whatever you are seeing most commonly in your practice, first answer that. Fine. Okay. Bridget, go ahead. So now, what next, Anand? What you want?
Sir, I would like to basic blood investigations, CBC, creatinine, urine routine, and urine culture.
Okay. And
after that, sir, to confirm all this, sir.
Okay. CRP. And
CRP.
You don't want to do anything else?
The sonography, sir.
And sonography. Fine. So Swapnil, do you want to add anything to that in the basic investigation? Or you
urine exam, urine routine and urine culture.
That he has said. He has said.
Sir, HbA1c.
Exactly.
Okay.
That is missing. That has to be asked.
It should be there because it will show you that how severe infection can be.
Diabetes.
Yeah, and if it is very high, you should avoid any major procedure.
Yes.
Right?
So it is complete blood count, urine routine, kidney function test, random blood sugar, HbA1c, one ultrasound.
Now he is complaining of LUTs also. Will you like to do some investigation for the same?
Uroflow metric.
Okay. Uroflow. Okay. This is a very simple examination. Investigation. Okay, Bridget, show them.
So serum creatinine was 1.3, WBC count was 12,000, sodium was 132, and HbA1c was 7.2. Next, this is urine routine.
Swapnil,
Yes, sir.
do you think something is wrong with this urine routine, or it is normal? His WBC count is, I think, 11,000 or 12,000, correct?
Yes, sir.
And the patient had fever, chills, rigors, 5 days of antibiotic,
Yes, sir.
and still the pus cells is hardly anything. So what do you think? What has happened?
Oh,
In other words, sir is
probably
asking you, can you have a normal urine routine? In which conditions you can have a normal urine routine?
sir, in tuberculosis, we can have sterile pyuria.
But here are we suspecting tuberculosis? Sir gave you a scenario, no? 5 days antibiotic has been given.
Your thinking should be very basic. There
Yes.
is a fever, there is a diabetes, okay, and TLC is raised, and urine shows 3 to 5 only pustules. So why that urine is not showing the pustules? What everybody is expecting there should be many pustules in such urines, but it is not showing. So exactly.
Exactly. Stone obstruction.
Correct. One
If
is
it is
stone
a
obstruction.
complete,
Second, sir gave you
Complete
the
obstruction.
answer. 5 days antibiotic has been given.
Yes, sir.
Patient
And
is already
simple thing,
taken the
above the
treatment.
stone there is infection, below the stone is normal. There is no urine coming. It's complete obstruction.
exactly.
Complete obstruction.
So why you are talking about tuberculosis? If you do like this in exam, they'll take you there then.
Yes.
Talk about simple things.
Think simply and talk very cleverly in front of the examiner.
Yes, sir.
Okay.
Urine culture said no growth.
This is the ultrasonography. Swapnil or Anand,
Yes.
any one of you can just read it fast and let us know.
Even examiner says read the film, you have to start, no? Sonography of the KUB region. You are only saying KUB here, no?
This is ultrasonography of kidney ureter bladder. In middle row on left hand side, it transverse section of, such a longitudinal section of the right kidney, left kidney is seen, in which shape of the kidney appears normal. Parenchyma looks normal. Corticomedullary differentiation looks normal on the left side, with perirenal area looks normal. There is no obvious hydronephrosis or no stone is seen in the left side of the kidney. Then, sir, on the second plate, there is a mild hydronephrosis seen in the kidney with with mild nephritic changes. And sir, in the bladder plate, transverse and sagittal plate looks normal. One plate is taken with full bladder, and another taken after the urination. That is, post-void residue looks minimal. And sir, prostate, sir, not able to make out the prostate in this plate, sir.
Good. So you read the report in detail, but just one small, very stupid thing, but very important thing. We are used to saying plate, but in the olden times they used to make plates. Now it is film. So some examiner might just point it out like that. So be careful. Don't say plates. You say film. In this film, you are not seeing. And very nicely, you have started and explained everything. But whenever you have the full abdominal film, you have to comment about the other organ also. Liver, spleen, gallbladder, pancreas are normal. And then you talk about kidneys, right, left, whatever, hydronephrosis, whatever your findings. Same thing with CT scan. When you get a CT scan or even of KUB and you are seeing some liver, spleen, gallbladder, pancreas, just make a comment. Because in exam, you are expected to see everything. Suppose there is a gallbladder stone, then you should say that there is a gallbladder stone. However, it is not symptomatic.
Sir, before saying about kidney or after the finishing about the kidney?
Yeah, so you can start with KUB
comment.
and then make a comment about rest of the organs. Or you can say this is a CT scan of abdomen pelvis. liver, spleen, gallbladder, pancreas normal, and then you start on kidneys, that this is right kidney, left kidney, whatever stone is there, stagon is there, whatever hydronephrosis is there. Findings like that you have to go.
Yes.
So what next?
Brijesh, just show the report and go ahead.
Just read it out, Brijesh. Read the report to them.
Impression.
The kidney is normal in shape, size, position, axis, and contour. Renal parenchyma appears homogeneous equal texture. There is no evidence of any nephrolithiasis. Mild hydronephrosis, hydroureter on the left side. No hydronephrosis, hydroureter on or calitaxis on the right side. Left kidney measures 9.6 by 4.4 centimeter. Ureter, lower ends of the ureter seen through the sonic window of full bladder are normal. The prostate measures 26 cc. And no any evidence of hypoechoic areas or no calcification seen. Mild hydronephrosis, hydroureter on the left side, grade 1 prostatomegaly, and mildly increased post-void residual urine. CTK be recommended for.
So what are the things they have reported wrongly in that report?
Sir, post-void residue mildly increased. Sir,
Exactly.
it's
So
looks
advising what we have to do, that is none of their business, number one. Number two, significant post-void residue. Very controversial issue, topic.
yes.
But no one has defined it, what is meant by significant. So someone has told it is 100, someone has written it is 200. So it is for the 300. So 300 plus, it suggests urinary retention. 500, yes, it is 100% urinary retention. So pre-void, it is related to the pre-void. Suppose, for example,
Relation to
pre-void
the
is
volume of
1000 cc and post-void is 100 cc. Is it a significant?
No, sir.
no, sir. At least more than
So
20%.
golden criteria described in various journals and book, it is 10 percentile of the pre-void or more than 1/3 of the pre-void. Both are described. तो आपका इंस्टीट्यूट में जो होता है वो बोलना. Then another thing is single post-void residue doesn't have any significance. Okay. So post-void residue 17 cc in pre-void is 56 cc. So that means that bladder is not filled up to the capacity. Okay. The first when the patient says I have a first arch, मुझे अभी जाना है. Oh, that is the normal capacity of that particular patient, and measure that particular amount as a pre-void. Ask him to pass the urine and measure the post-void. Most accurate way of measuring the post-void is placing the catheter or by sonography. So if it is more than 1/3 or 10 percentile of pre-void, then it is called as significant. So it is 56 is also not a good normal capacity bladder, and 17 is also not a significant post-void residue. So both things are reported wrongly. Then advising non-contrast CT scan. Why he has advised non-contrast CT scan? So
Sir,
left mild hydronephrosis, probably he may have not able to find the cause.
because
That's
of
why
gas shadow.
he has suggested you to do the non-contrast CT
No,
scan. So you want to do a non-contrast CT scan, you want to do don't want to do a CT scan, or you want to do a contrast CT scan, it is your business. And you have to define in that. So what you want to do now?
Justify whatever you say.
Sir,
So the sonography
like
shows
to
mild
do-
hydronephrosis, hydroureter on the left side. So probably there is an obstructive cause along the left ureter somewhere, which was not seen in the sonography. So I would like to do a non-contrast CT to further see for the cause, and also if there is any perinephric fat stranding or periureteric fat stranding to rule out pyelonephritis.
Okay.
So while suggesting a non-contrast CT scan, ultrasonography, cortical thickness, amount of hydronephrosis, उतना कुछ ज्यादा डेंजरस नहीं है. फंक्शन नहीं रहने का कम चांस, नहीं फंक्शन खत्म होने का या कम होने का चांस कम है, तो ऐसे सिचुएशन में कॉन्ट्रास्ट सिटी स्कैन किस लिए करना है? एनाटॉमिकल पाथवेज देखने के लिए करना है, फंक्शन असेस करने के लिए करना है। वो दोनों भी अभी अपनी प्रायोरिटी नहीं है। अपनी प्रायोरिटी ये है कि व्हाई देयर इज हाइड्रोनेफ्रोसिस एंड वेयर इज द ब्लॉक. So ultrasonography is not a foolproof method to assess the lower ureter. Operator dependent, lot of in emergency, lot of gaseous reverberation, a number of the problems which may avoid or block the complete finding of that particular area. So best way in emergency patient is in colic. Gold standard investigation for any ureteric colic is non-contrast CT scan. So I am advising non-contrast CT scan.
Yes.
Yes.
Fine. Okay. Along with that, you had asked for the uroflowmetry. No? Just show him uroflowmetry. Yes, Swapnil. So what is your impression?
So the uroflowmetries are voided volume is 190 ml. 190. Qmax is 15.4. Voiding time is 27 seconds. Voiding time is 34 seconds and average flow is 7.1. So at looking at the graph, it shows like a obstructed pattern, sir.
He is a 73 years old male.
Yes, sir.
For this age, we should repeat the urography again, uroflowmetry again, and sir, Qmax is 15.4. It may be in the equivocal zone between 10 to 20.
What is your criteria to label it as obstructed? Only on uroflowmetry.
Qmax
As
less
per
than
the literature.
10. Sir, Qmax less than 10 milli per second is labeled as an obstruction, sir.
How much is the Qmax in this patient?
Sir, 15.4. And sir, Qmax more than 20 falls under non-obstructed, and 10 to 20 equivocal, we can label as equivocal.
So do you think this patient has voiding LUTs?
Sir, he had increased frequency, sir.
My question was very specific. Do you think he has voiding LUTs?
Okay.
Sir, no, sir.
Rahul.
No, sir.
Frequency. Frequency is the symptoms of prostate or symptoms of a bladder.
What is the ICS nomenclature, Rahul? What is
Yes,
ICS?
Frequency, urgency, and nocturia related to.
What is the nomenclature? What is ICS stand for?
International Continence Society.
Okay, so what have they defined now? Is it called voiding? Is it called obstructive and irritative symptoms anymore?
No.
No, sir. Storage and
Voiding
voiding
and
symptoms.
storage.
Voiding and storage. So I asked you,
Yes, sir.
does the patient have voiding symptoms? So what are the voiding symptoms? Peace and fun. Fun is
Sir,
storage symptoms.
straining, poor strain, hesitancy, and sense of incomplete voiding.
Yeah, so peace, poor flow, intermittency,
Yes, sir.
straining, sense of incomplete evacuation. Fun
Yes,
stands
sir.
for frequency, urgency,
Yes,
nocturia.
nocturia.
This has to be on the tip of your tongue. Okay, so those whatever symptoms he had was defined as lower urinary tract symptoms. That could be because of some stone or irritation in the bladder. He doesn't have any voiding symptoms. Okay,
Yes,
Yes, sir.
yes, sir.
go ahead.
Go ahead. Show the CT. Okay, we have only report of
Yes.
the CT scan, first CT scan.
So there is a mild hydroureteronephrosis due to calculus at the vesico-ureteric junction measuring 9.1 cross 9.1 cross 8 mm with mean attenuation of 1450 ounce per unit. There is mild perinephric and periureteric fat spending with renal facial thickening. Prostate is normal for the age and a defect of 2.2 centimeter right inguinal region with herniation of the omentum.
And the last
So
line. There is a
There
mild
are other important findings
left
also. Pleural effusion.
Left pleural effusion with collapse or consolidation of underlying lung segments.
Is that an important finding or not?
Yes, sir.
Yes, sir.
Now what will you do?
Sir, I would like to counsel my patient about the treatment options. And sir, accordingly, I would like to do, sir, left side semi-rigid ureteroscopy.
Beta, you
Plus,
said treatment options. I would like to know what options are
to,
there in this case.
sir, endoscopic, endoscopic only, sir.
Then why did you say options?
And
So
sir,
you have to be a little smart in the exam, okay? You have to be a little smart.
yes, sir.
Now, if you're talking about localized prostate cancer and then you can say options of radical prostatectomy versus radical radiotherapy, I can understand. In this option
Yes,
means
sir.
you have to talk to the patient. Now there is a stone at the junction. So what you're going to counsel the
Okay,
patient?
sir.
Are you going to do open
Sir,
ureterolithotomy for VUJ calculus?
no, sir.
No, sir.
Then
राहुल, यहाँ पे ऑप्शन में दो चीजें हो सकती है, जैसा कि
PCN you can tell.
if I am a student exam going, I will defend it like TLC is 12,000, patient had a fever,
Correct.
patient
That
had
option.
lower ureteric stone, patient had a hydronephrosis, patient is symptomatic, patient is diabetic. So I will place stent and I will come back. If stent is not going, then I will take
Correct. So
consent of
options in the
इतना बोल
form
के मैं
of
चुप हो जाऊंगा.
drainage versus removal of stone. That could be option.
Yes.
So whether you want to put PCN or degestant. So again, now this comes to the discussion with the patient. When you are sitting and discussing the patient, you have to explain all these things. What can happen? Whether you would like to intervene, not intervene, whether the patient is very sick, not sick, whether the patient is fit for surgery, not fit. There can be various scenarios. Patient may be toxic in septicemia. Then you will not go for URS, right? Patient could be on blood thinners. Then you have to do
Yes,
URS
sir.
very carefully, or you may just take a call or wait for 1 or 2 days.
Okay, I will just
Yes, sir.
tell you one thing. Before, Bridges, just tell them, do you want to do any? He's a 73 years old. He has got now the left-sided pleural effusion. He has got a left-sided severe pyelonephritis. Any other investigation you want to do before going for any intervention? Rahul, Swapnil, Anand, any one of you, any other basic investigation pre-operatively?
Chest X-ray, sir.
Yes, yes, sir.
Very good. Chest X-ray. And what else? You don't want to know anything about cardiac status at the age of 72?
2D, sir.
Sir, 2D echo.
Okay, Bridges, tell them what is the 2D echo?
3D echo ejection fraction was 22% and he had grade 1 diastolic dysfunction.
Okay, now keeping this in mind, let us have a little small debate between Anand and Swapnil. Anand, you justify saying that you like to do PCN. And Anand, you try to justify or give your reasoning why you want to do degestanting SOS stone removal. So let us start with Rahul. Rahul, you talk about PCN. You try to justify PCN.
Sir, PCN can be done in local
Can be nahi.
anesthesia.
You want to do
It,
in the
Beta,
exam.
can be nahi. I will do.
In the
I will
exam,
do
you have
PCN.
listen. Rahul, in the exam, you have two choices, and now you are committed yourself, and you are telling examiner, "Okay, sir, I will like to do PCN." So now you want to justify that why you want to do PCN in this patient.
Sir, local anesthesia.
No, first tell us.
Then
That is the
sir,
secondary. Why you want
Beta,
to
you
do
have to
PCN?
say that, sir, in this case, I would like to do PCN because I will like to do PCN because I will. I.
Okay, sir.
अभी बोलो आगे.
Sir, I will get to know renal function, then
why you want to
as
do?
well as urine output from the PCN. Then
Rahul,
So
ये
sir,
patient
we
is
can do
patient
73
You have
obstruction.
to
यूरिन
prioritize
आउटपुट
your
कम आने
answer,
वाला होता
beta.
है
so
पेशेंट का
patient is
किडनी का
73
साइज
year old male. He is
है
diabetic.
कि नहीं
You have to
One second.
prioritize your answer. He's an old man. He's sick.
Patient is
He's
70.
diabetic. He's having high TLC. These are the priorities.
Ejection
Then other
fraction
things
is
like putting it in local anesthesia, ultrasound guided can be done at bedside. All these are little later on. The first
Okay,
thing
one
is
second.
that he's
Anand wants to answer. Anand, you justify. Chalo, you
yeah,
are
Anand.
given a choice.
Well,
Yeah.
Sir, I would like to do PCL because the patient is 70 year old, diabetic, and his ejection fraction is towards lower side. So giving him anesthesia is little high risk, sir. And
All of you are missing the train.
So patient is 73-year-old diabetic. He's toxic. His counts are raised. His creatinine is raised. His HbA1c is deranged. Probably uncontrolled diabetes. And there is a
pleural
obstructive
effusion, sir,
zone at the left VUJ with perinephric periuretic fat staining. So so PCN can be done, which can be done bedside under local anesthesia, and we can drain the active infection from the kidney and start him on antibiotics. When the patient stabilizes, fever settles, count settle, we can go for definitive management.
So during
Exactly.
definitive management, any other advantage of PCN?
So we can use the same tech for the further procedure also, sir.
No,
Sorry?
no, no. The stone is at the lower end.
Lower
Yes,
end,
sir,
na?
sir.
Lower end. Low pressure
Therefore,
system. When you're
Low
doing
pressure.
URS,
Yes, sir,
it will
yes.
be a low pressure system. There will be drainage, na?
two important points. Clinically suggestive of infection. Laboratorically, there is no pustule. There are chances of having a complete obstruction. Going a stent is difficult. One. Another thing, if it is infection for drainage of the pus, PCN is better than the digestate. 2.
Yes, sir.
Number 3, local anesthesia versus need of anesthesia. Number 4, any invasive procedure, chances of post-surgery sepsis and need of ICU is more in DJ versus PCN. So these are patient is diabetic.
And last is cardiac status.
And last is cardiac test. These are the things which make me to think PCN as a primary de-obstructive way in this patient. ऐसा बोलने का छोड़ देने.
Very
अगर
well,
मतलब
sir has
है ना,
given the priorities.
हाँ, मेरे जैसा एग्जामिनर बोलेगा मैं लोकल में डिजेस्टेंट डाल देता हूँ, कई को PCN करने का. फिर वो अनकंट्रोल्ड सेप्सिस है, उसका कोएगुलेशन प्रोफाइल डिरेंज होगा या फिर और कुछ होगा, ब्लीडिंग हो गई.
Now, sir, the stenting fellow has to say his answer.
Yeah.
Yes.
So who is answering? Anand.
डोंट वरी, जो भी आता है वो बोलो, बच्चा
बोल
वाला
बोल
हम
बेटा.
बोल देंगे.
Yes, sir. The stone is at the lower ureter, sir, exactly at the VUJ. So removing the stone is
See, in this patient, Anand, in this patient, we are talking of this patient. Okay. This patient was treated for 5 days with IV antibiotics. Correct? His fever, everything has subsided. Right? Second important thing is his count is not very high. It is only 11,000.
marginally raised.
Urine is not showing pus cells. Patient is otherwise well settled. His cardiac status is such we cannot keep on doing intervention again and again. Right? And you will like to treat him in one go if possible. So that is the reason you will like to do bigger stenting, SOS stone removal, and if it is impacted in bedside, that time only we will do PCN. Now, if this is the answer, now you tell me how you are
And
going
you
to
can
put it.
also say the problems with PCN. So maintenance of the PCN
Yes,
can get
maintaining
slipped
a
out,
PCN bag,
can have
And as
bleeding.
Dr. Gite has said very
skin
rightly,
exfoliation.
Dr. Gite has said very rightly that there may be deranged, even though your
Correct,
DPPT-CT may be normal, but when you do
correct.
puncture, there may be a
You can
bleeding,
you can have bleeding, you can have other organ injury. It's a blind procedure, whatever. All those things you have to defend yourself. So when
and
sir
then
has
say,
put you against the debate,
Okay.
every point should be covered.
so now tell us, come on, Anand, you know all these things, what Dr. Gite has said, what I have said, Dr. Hiren has said, and you have the ideas. Tell us in one sentence. Defend yourself.
Yes, sir. Considering his age, sir, and his cardiac status, he is not going to be subjected to multiple procedures. And doing PCL is having the complications of PCL are like keeping bag and skin exfoliation. I would like to give him the options of degescenting or removing the stone in one go, sir. That is URS, sir. And the moreover, the creat is marginally high and count is marginally high. So I don't think the patient is toxic, and he has already taken the antibiotics for 5 days.
Again, you said most of the thing, but you said in the wrong line. First, what will come is that this patient has already received antibiotic. He has improved, correct? He is not on
Yes,
an inotropic, or his vitals are absolutely normal. His WBC count is not much raised. His creatinine is only marginally raised. At present, he is fit to
I
undergo
would like to
procedure.
give him a chance of definitive management.
If the DJ scientist or I'm not able to do it in the one go, I will immediately do PCN and come out. You understand? So this is the way how to defend yourself. Fine. Okay. Let's go ahead. So, Vijay, tell them what we did.
Sir, another way, if examiner asks you, do you do ureteroscopy right bang on in first sitting? So उसका आंसर ये है कि I will do cystoscopy, I will do RGC, I will see the color and clarity of the urine, and I will decide to proceed or
Fine.
not.
I think this is a better answer. Okay, just show.
The patient intervened left URS and degescating, and on cystoscopy, possible urine from left UJ was noted. Urine culture from that urine was sent intra. On post-op day 1, patient was lethargic and difficulty in talk. Investigations were also done. So this was the investigation. We could see his hemoglobin was 10.4. His WBC has been raised to 26,000.
Show them other investigation.
And pulse was 88, blood pressure was 116 by 70. Urine output was reduced to 800 ml in 24 hours. His serum electrolyte sodium was 126 and potassium was 3.4 and create has raised to 3.9.
So, Swapnil.
Yes, sir.
You
What do
said
you
you
think
like to do. No, yeah, you said you like to do PCN, correct?
Yes, sir.
So you think you were wise to say that?
Sir, I think because URS was done and degescenting was done, the operative time was more. Also, there was pylolymphatic and pylovenous backflow
The
that might have
question
increased.
of the examiner was, were you wise to do a PCN? So you should say yes, sir. I
Yes,
would
sir.
have definitely done PCN. Why you are
Yes,
telling what has happened in PURS? Question is very specific. Are you wise in doing PCN?
yes, sir.
If
Okay.
examiner
Anand?
has asked you what gone wrong in this procedure or
Then you
what
tell
gone
like this.
wrong in this condition in this patient which is post-operatively having this problem, then you can say okay, already there is a notes written. First, there is a frank pus drainage. So if the patient is infected, any endoscopic invasive procedure should be avoided. That is the bottom line. So placing a digestant is the correct answer. So particularly if you have already gone in and placed the digestant, but doing a ureteroscopy in presence of pus
Yes, sir.
is not a good idea, at least in the exam.
Understood?
Yes, sir.
Fine. Okay. So, Anand, what is your say? You were defending DJ stenting. So, in this case, what you will say? Yes, Dr. Gite said that I would have put only DJ stent if there is a flank part. Yeah, correct. Understood. Fine. Okay. Now, Bridges, tell us next what happened.
So the intra of culture and sensitivity report which we sent it came to be Candida glabrata. Fungal.
Okay. So now, Rahul, Swapnil, and Anand. Now, you understood
Yes, sir.
that in spite of good coverage of antibiotics and in spite of making patients febrile, WBC count decreased. In spite of that, why patient developed this problem?
Due to the fungal
infection.
Why do you think there is fungal infection?
Uncontrolled diabetes.
diabetes,
Opportunistic. So,
opportunistic, immunocompromised host.
yeah, correct.
Fine. So now what you will do? What medicine you will give? Fast. We have to take now the second case. Say, beta, which medicine you like to give?
Sir, according to the sensitivity, capsofungin or variconazole can be given in these patients. After correction with simultaneous correction of sodium,
yeah,
as well.
Correct. So we increase the antibiotic higher dose, started antifungal and corrected, and within 48 hours patient improved. Okay.
So antifungal was started, sodium correction was done gradually, and over 3 days, pulse became normal, blood pressure and urine output became 2,600 ml, sodium and potassium and create also came back to 1.4, which was his baseline was 1.3.
So you can say that even though we did URS in presence of first, okay, and patient has deteriorated, but ultimately he has improved. So it is not because of your only management, it is because of patient's response as well as God's response. Okay, fine. So now you understood the model of the why we are putting these cases, so that in practice as well as in exam, you will come to know what answer you should. Fine. Okay. Because every case is different. Bridget, second. Please unmute yourself, those who are not answering. Bridget, second case.
ये बोला गया है ना 2.5 लीटर बोला गया है.
So 50-year-old patient, female patient presented with a complaint of pain over right flank since 15 days and fever with chills and rigor since 7 days.
Okay, Swapnil, fast history and then we'll go ahead.
Yes, sir. I would like to know the onset, duration, and progress of the pain, the nature of the pain, any radiation, any medications that were taken, associated with vomiting, nausea, fever, chills, rigors, any hematuria, lithuria, pyuria, any passage of stones, any previous endoscopic surgery was done, and any other urinary complaints.
Fine. Bridget, just tell them the full story.
Patient was asymptomatic before 15 days and developed pain in right flank region. Pain was sudden in onset, radiating from right loin to groin and was relieved on taking analgesics. Fever and chills with exertional dyspnea since 7 days. Fever was high grade continuous and was associated with tachycardia and low blood pressure, for which she was admitted in ICU and was managed with IV antibiotics, antipyretics, and
An analgesic.
There was no
Right.
history of hematuria, puffiness, no bleeding disorder, anticoagulant therapy or blood transfusion.
Okay.
The patient was a known case of hypertension, was managed by telmisartan 40 milligram and was well controlled blood pressure. Had a history of right ureteroscopy in the past for ureteric calculus, but no other documents were available. So she was managed in the ICU with bladder was Foley's in situ. Since 7 days, she had reduced the sleep because of the symptoms and had no any addiction, non-alcoholic and non-smoker.
Fine.
Okay. General examination. She was well oriented to time, place, and person. Her weight was 52 kgs. Blood pressure was 106 by 70. After resuscitation and conservative management in ICU, pulse rate was 112 beats per minute and KFS was 90. She was maintaining 98% on 2 liters of oxygen and no any evidence of pallor, icterus or cyanosis. On the general examination, patient was examined from head to toe in supine positive implant consent.
It
and
was normal.
external
Local
genital
examination was normal. Correct?
normal. Yeah, there's mild tenderness on the right flank region, sir.
Okay. Tenderness in the right flank region. Fine.
Yes.
Okay. Yes. So now, Rahul, what you want to do?
Sir, I would like to stabilize the patient,
Yes.
correction of hypotension, as well as I would look for the simultaneously look for the urine output of the patient by connecting the uroflowmeter to the catheter, as well as I will upgrade the antibiotic according to the urine culture sensitivity. And after the stabilization of the sir, I would like to repeat the investigations, laboratory investigations, and I would like to add the ultrasonography, bedside ultrasonography, to know the exact cause of the fever, chills, hypotension. Sir, I would like to this.
Okay, Bridges, show them.
So WBC count was 17,000. Creatinine was 0.9. Hemoglobin was 10.8. And the rest, all electrolytes and sodium potassium were relatively normal. Urine routine micro.
First cells was 4 to 5.
4 to 5%.
That is it. And the red blood cell was 60 to 70. And this is the sensitivity. So which antibiotic? Yeah, Rahul, which antibiotic will like to give? There is a nitrofurantoin also, and there is a meropenem and
Sir,
ertapenem also.
Sir, I would like to start with amoxicillin plus clavulanic acid, sir. After that, sir, first start with broad spectrum antibiotics, and culture shows Escherichia coli colony count greater than 10⁵. So, sir, amoxicillin plus clavulanic acid, good option. And sir,
What is the MIC?
then I would
What is the
sir,
MIC mentioned
8.
in the report? So is it good
Sir,
choice?
it's 8 mentioned in 8, sir. Sir, higher antibiotic can be given, but we should start with broad spectrum antibiotics. Then, if it is not giving response, then we should step up, sir.
Listen, if there is a complicated urine tract infection, if it is a normal urine tract infection, what you are saying is right. But if it is a complicated, when you want to save the life, you cannot start from the basic. You understood?
Yes.
So in this case, because first when she came, she was in hypotension because she had, cardiac status affected and she was in septicemia. So this is a time when you have to start a higher antibiotic. You can't wait.
I agree with
Every
sir.
hour is
And
important.
And this culture report has a lot of significance. When the MIC is mentioned and it is 8, you think is it going to work immediately? And again, while answering,
Sir,
you are
it will-
saying we can do this and we can do that. We don't want to know what we can do.
I will do the.
What?
Sir, sir, I will
Correct.
do. Sorry.
Okay, so anyway, the higher antibiotics like meropenem or ertapenem was started, either of them. And now patient is totally stabilized. After 5 days, she was off oxygen. Okay, there was no fever. Count had come down to less than 10,000. Creatinine was normal. Now what you'll do? And sonography, no? You
Sir,
had
I
asked
would
for the
like
sonography.
to see the sonography. Yes, sir. Yes, sir.
Yeah, so Bridges show them sonography.
So
Just read
USG,
conclusion.
USG suggested of a calculus of 1.2 centimeter in the gallbladder, and right kidney, the parenchyma had altered ecostructure, and corticomedullary differentiation was maintained. It was showed an isoechoic lesion in upper pole cortex with internal echoes. Mild pelvic cell fullness was noted. The impression was bulky right kidney with altered ecostructure, and minimal pelvic system fullness, both in pyelonephritis along with evolving abscess in upper pole and solitary gallbladder techniques.
So, Swapnil, what you want to do now?
So since the patient is now stabilized of O2 on antibiotics, I'd like to get a CT scan done, sir. No, non-contrast CT scan.
Okay. Bridges show them CT scan. Yeah, one of you can read it.
This is the non-contrast CT scan of the abdomen.
Pardon?
Non-contrast CT of the abdomen and pelvis. The left kidney appears normal. The right side appears hypertrophy with dilatation of the PCS, grossly dilated PCS with perinephric fat stranding.
And you can't see the stone at the end, lower end.
There is a radiodense opacity at the right VUJ, most likely a stone. And the entire with gross hydroureteronecrosis.
Any other plate is there?
No, sir. No plates.
And no, okay. Ultrasonography was suggestive of evolving abscess in the upper pole. Can you see it? Are you able to see it? Swapnil?
No, sir.
Not able to.
You are not.
Appreciate.
Right. So it is not there. Correct?
Yes,
so now next what? Now what you want to do? Come on, this case, that is why we are keeping different cases.
Yeah, so there is a obstructive calculus at the VUJ with gross hydroureteronecrosis. Patient is now stabilized, so we can. I will go forward with ureteroscopy and laser lithotripsy along with DJ stenting. If there is pus or I'm not able to pass the scope, then we can we can stage the procedure with DJ stenting and at a later date. we can go for definitive management.
So who Swapnil has answered, correct?
Yes, sir.
Okay. Rahul, you want to defend?
Yes, sir.
Yes, sir.
It is obstructed system, and patient had a history of urosepsis previously. So better choice is to stent the
No, one second.
patient.
Patient had a septicemia, urosepsis, toxemia. What was that? What is the meaning of urosepsis?
And sir, due to the obstructive
SRS plus
uropathy, patient had a hypotension, tachycardia.
So when you say patient has urosepsis, and when you say patient has got septicemia or toxemia.
Sir, due to the obstruction of genitourinary tract, which lead to the septicemia, that is called as a urosepsis, with associated with azotemia, with or without.
So how many systems should be affected in urosepsis?
Sir, urinary system as well as any other system can be involved in the urosepsis.
So 2 or more systems, correct?
2 or more, yes.
Fine. Okay. Anand?
Yes,
you want to defend? You want to do something else?
Sir, I want to defend it, sir, because as the ureter is obstructed, I want to remove the obstruction. And now the patient's counts are slightly, patient is
It is
stabilized.
normal. Everything is normal.
Yes,
Patient is all
yes, sir, I will
anatropic.
go to definitive procedure, sir.
You want to go for a definitive. So Anand wants to go for a definitive procedure because patient is young. You say that patient is young. Correct?
Stabilized.
Number 2, she has got no other comorbidity. She doesn't have diabetes except hypertension. Only hypertension is there. Right? Her rejection factor is also good. She has received full treatment depending on the culture and sensitivity. Count has become normal. Creatinine is normal. At present, she is otherwise fit. You would like to go for a definite treatment, right?
Yes.
And the stone is lower down. There are very high chances that with minimum intervention, you will be able to give the treatment. Yes or no?
Yes, sir.
Yes, sir.
Yes. In this case, the stone is how big?
So 15.7 mm.
15.7.
So, what? Anyone for a PCN? No? Okay, let's go. Vijay, tell them what happened.
So patient underwent cystoscopy with right urinary adenoscopy and TFL, thulium fiber lithotripsy with DJ staining. On post-op day 2, patient developed fever and pain in the right flank region. Investigations were done. Blood report showed hemoglobin of 10.2, WBC of 18,000, create was 1.2, ESR was 60.
Yes. So now what you want to do, Rahul?
Yes. Sir, upgrade the antibiotic as according to the sensitivity.
Culture. Okay.
To control the infection, and after that, sir, we can observe the patient.
Okay. Anand, were you expecting that there will be a rise in WBC count?
Sir, due to the procedure, it
may
be.
It is transient, right? I would just observe the patient. Sir.
Okay. So now this patient is complaining of severe pain in the right flank. See, normally I understand.
Sir, maybe,
normally, even if you are doing a normal, listen, even if you are doing a normal ureterinoscopy or PCNL, post-operatively, there will be some rise in WBC count. Yes, there may be transient. Here it is more. according to I have seen so many patients and we routinely do it. I have seen that more than 14,000 in my practice I consider as a significant because these patients may have infection, or if it is less than 14,000, we don't change anything and they respond very well. So here it is 18,000. So definitely. And we were expecting because it was a closed system. So even if everything is normal, when you do ureteroscopy or you do any more intervention, okay, except even degescenting might have caused this rise. But why she is getting pain in the right flank? You
Because,
don't want to do any investigation for that?
Sir, maybe, sir,
sir,
Yeah,
maybe,
let Dr.
sir,
Gite
maybe
say.
due to
1 second.
recently
Yes, sir.
infected system and patient in urosepsis cleared by antibiotic. As sir has already told, it is a closed system. Size of the stone is 1.5 centimeter. Duration of the surgery may be slightly longer considering the size of the stone. So whatever the irrigations they have used, that irrigation at present system may be sterile due to antibiotic. But whatever the pressure used, that all things can be intravosated in the intraperitoneum and patient may be in the sepsis post surgery. So why he has pain? So whatever the fluid they have used with whatever pressure, definitely there are chances to leak that fluid and went in the perinephric area, which we have to rule out by doing some investigation, because that is one reason. Another reason, stent may be up migrated, down migrated. One of the stone may have impacted, again come down and impacted at that place. Along with stone, there is a complete obstruction. So this is another story. So ये सब चीजें देखना भी जरूरी है. अभी पेशेंट
Yes.
सेप्सिस 18,000 मतलब कम नहीं है. That is a very something.
Yeah. And of course, when he has not mentioned you properly, but when we do the URS, it was a big stone. So we have broken the stone, and because it was a closed and infected system, we removed only few pieces and we have put the digestion. So definitely there are some stone fragments still inside the system. So now what you want to do? Rahul, you
sir,
tell what
bedside ultrasound
you want to
will
do.
do.
Ultrasound. Okay, Rahul wants to do
Sir,
ultrasonography.
ultrasound,
And
sir.
no.
Ultrasound.
Okay.
Yes.
Ultrasound. Anand, what you want to do? Ultrasound?
Sir, I would like to do CT scan, sir.
CT scan. And what about Anand?
Non-contact.
And what about
Okay.
yeah,
Swapnil.
Swapnil, what you want to do?
Ultrasounds.
Very good. So no problem. All of you are right. If first stage, you may do sonography. Suppose sonography is not showing anything, you may not spend extra money. Or if it is showing something, then instead of doing plain CT, you may like to do contrast analysis. Correct?
Contrast analysis.
Right?
Yes.
So you answered properly. Okay, show them ultrasonography. Bye.
So in ultrasonography, there was a perinephric hematoma machine measuring of 10 by 5 by 7 centimeter with digestant in situ. And there was a 4 mm calculus in left kidney.
Fine. Go ahead. So next, we did the CT scan, as you all of you advised. Show them the plates of the CT scan. Can any one of you comment? Rahul,
Yes,
very
sir.
simple, beta.
Sir,
Say something.
this is axial CT scan of the abdomen, suggestive of the collection on the right side of the kidney, perinephric area.
Is it perinephric or subcapsular?
Sir, subcapsular looks like subcapsular area. Sir.
Yes. Okay.
Yes, sir.
Mainly in the upper pole, correct?
Upper pole region.
Upper and middle, just correct?
Yes.
So now what you will do?
So size of the collection is 10 into 5 centimeter, causing compression on the kidney. So, sir, I will do the right side PCN to drain the collections.
PCN will drain it?
Sir,
Is it PCN
it's
or PCD?
pigtail, sir, pigtail 10 by 22 French pigtail can be able to drain this, sir.
So what is this? Is a pus, is a fluid, or it is a clot?
Sir,
What are you worried about?
sir, maybe if it is blood, so source of blood may be due to the sir bleeding
How
inside
blood
the
looks on CT scan?
What are you worried
Non-contrast,
about? You're worried
freshly
about the
done
source of the
procedure.
blood.
How it looks on CT scan. If you know that,
sir,
you are ready with your answer.
And are you worried about the nature, the source of the blood? What are you worried about? Source may be anything. Now, post URS, it is bleeding has happened. What are you worried about? What is page kidney?
Page
Yes, sir, page
page kidney, sir, due to the compression, subcapsular compression can lead to the page kidney.
What else can happen to hematoma?
Sir, hematoma can get infected and cause
Correct.
abscess, abscess and
Correct. So you have
abscess.
to tell what are the consequences of hematoma now. So one was page kidney
Sir,
compression, which may be increasing. If it is increasing, you have to drain it.
Yes, sir.
Second is if the hematoma gets infected. You said that you will place a drain. So can PCN also help, or you would like to place a pigtail in that? And sir was asking, what is the nature? Is it a clot or it is fresh blood? If it is a clot, is it going to help putting that PCN?
Sir, no, sir. Clot. Sir, it's look hyperdense. Clot looks hyperdense on the CT scan, and sir, it is looking hypodense. So it may it is.
Please place the CT film on screen. Yes. Now see.
Yes, sir.
What is that?
Sir, it is hypodense area.
It is a clear fluid with enhancing
with
capsule.
Yes, sir.
Around.
Surrounding area is hyperdense,
and the kidney is pushed to one side,
towards
that medially.
medially, pushed to medially.
Do you think that is a blood? If you want to confirm, ask for Hans
Yes, sir.
unit.
Yes, sir. Sir,
but fresh blood, it looks like white on the non-contrast CT scan. See the non-contrast film.
Yes, sir.
कहीं white दिख रहा है क्या किडनी के एरिया में?
No, sir.
नहीं दिख रहा है. See the contrast film. Check the density. It is a clear, transparent fluid. So what it could be? It is definitely a subcapsular urinoma. So you want to drain or don't want to drain? Patient is symptomatic.
Yes, sir.
It's compressing to the kidney. I want to drain. So how you want to drain? By doing the PCN or PCD. PCN may not be helped because it is inside the system. And if the communication has lost, then that fluid may not come inside the system. So but it is better to place the PCD in the collection. And already there is another tube which is there for draining the system. So my answer will be PCD. So why it is not hematoma? Two, you have to ask two questions to the presenting person. One is Hansfield unit. Internal echo पूछा क्या वो भी पूछना है report में. हमको लग रही नहीं है लेकिन अंदर कुछ है क्या? ये दो चीज अगर निगेटिव
Sir,
है तो इट इज
internally cause should be asked.
व्हाट?
Sir, internally cause should be asked in CT also.
हाँ दिखता है ना, फीलिंग
Yes.
डिफेक्ट नहीं दिखेगा, कॉन्ट्रासिटी है ना।
Yes, sir.
इंटरनल इकोज ये सोनोग्राफी का टर्म है, लेकिन सिटी स्कैन पे अंदर कुछ मटेरियल है तो वो दिखेगा कि नहीं दिखेगा?
So now
Yes,
you
sir.
got an answer to what you had said. Initially, you said I'll do a non-contrast CT. When there is a complication, then what is the role of non-contrast CT? Creatinine is 1.2. To get all these answers, you need a contrast CT. Non-contrast CT will not tell you whether it's blood, this, that, whatever.
So what they have reported as a perinephric hematoma, it is a subcapsular collection. That's what I feel after seeing that CT film. Let's see what has happened and what
Let
has
us
done.
ask sir now what was done now. Sir will tell, because I think the ICU fellow was also insisting that we should do something.
Yes.
Sir,
Gaurang Shah, sir.
Sorry. So, considering all these things, facts, we also, like you thought, it is a fluid. Okay. So I tried to put under ultrasonography guided a pigtail. So first we put a needle and aspirated. It was only the little amount of about 4 to 5 cc of thick blood which came. So we decided that to abandon the procedure. And then I again went to the senior radiologist. He saw it again, everything, and he said, no, it is a clot. There is no liquefaction. So you don't do anything. So we waited for 4-5 days. Patient had improved, no fever, hemodynamically everything fine. And I told them that we will do CT scan after 15 days. But that day again, the intervention fellow, he said we will do CT scan. But show the second CT scan. You don't have second CT scan with you?
Bolo ji, what has happened now?
No, this
Sir,
is the third CT. Huh? This is the third CT.
this CT after 6 weeks.
Yeah, no, this is the third CT. So second CT again, he said the same thing because there is a liquefaction. Since the patient had little fever, we decided to put a drain, and the 14 French pigtail was kept, and see what we got. Okay, 30 to 40 cc serosanguinic and serohemorrhagic this thing fluid. It was basically a hemorrhagic fluid which was drained. We kept it for 4 to 5 days. Nothing was coming. So again, I went to the radiologist. We saw all the films. He said it is not liquefied. It is going to be useless. Either you go inside and remove the clot or you don't do anything. So we decided to wait. Patient improved. We sent her home. Now what you will do? Rahul.
Sir, we should follow up the patient
Yes.
with ultrasonography.
Yes.
I will follow up the patient with DTP scan.
Okay.
Yes. That is actually answer.
If
Sir,
that kidney has
sir,
compressed,
should,
if that kidney has compressed throughout last 3-4 procedures, and we have not done anything for decompression in this patient, so it is end up definitely with a page kidney, because all the fibrotic area has catched that kidney and compressed completely. So First CT scan, what my opinion is, there is definitely a clear fluid. Maybe surrounding hematoma है, ऐसा लग नहीं रहा है, लेकिन अगर सीनियर रेडियोलॉजिस्ट ने बोला है तो शायद हो सकता है. अपन कभी कभी रेडियोलॉजी में थोड़े कच्चे हैं तो, लेकिन जो साइंटिफिकली हंसफील्ड यूनिट और उसकी जो ट्रांसपेरेंसी है, क्लियरिटी है, वो फ्लूइड की है, नंबर 1. सो वहां पे कैसा भी करके अगर पीसीडी अर्ली फेज में अगर डालते थे तो शायद वो कॉम्प्रेस जो भी हुआ है वो कम हो सकता था. अभी उसका टाइम चला गया. इट इज वेल डेवलप्ड compression, and in spite you go inside and relieve that external compression by like a decortication in the thorax, then only that kidney will survive, otherwise that kidney will go. ऐसा होने का चांस ज्यादा है. अभी देखते हैं क्या हुआ है आगे.
Fine. So after 6 weeks, we repeated the CT. Show the last CT scan. Yes. So the next pill. Yes.
Sir, this is axial CT scan of the abdomen and pelvis. In as compared to the previous CT scan, on the right side, the collection seems to reduced in size, along with the hyperechoic area around the collection, suggestive of maybe absorption of that clot or collection with calcification. And sir, rest looks normal, sir.
So as now what you want to do? Just tell me 3 things what you want to do.
Sir, if we should look for continuously follow the patient.
Can you see?
And,
Can you see the lower end? Can you see the lower end of the DJ? And in between, can you see the stone?
Yes, sir. Stone is
Lower
there,
end?
sir, in the lower end.
Yes, sir.
Okay. So as your Dr. Gite very rightly said, we have to do DTP renal scan. That is what we are planning. What we did was, we removed the DJ stent today only. There were fragments which were left behind. So with the minimum fluid, we have removed the whole thing, all the fragments. And because there was little edema inside, we have put a new fresh DJ stent. Now, as Dr. Gite has suggested, we will like to do DTPS scan and then follow up the patient. Okay?
Yes.
But the answer is you must do DTPS scan in between. Or if you are worried about such a big hematoma, what you have to do is when the pigtail is kept inside, this is what I normally do. Put a guide wire through that and like a PCNS, dilate the whole tract up to 30
And remove that
Right.
too.
and put a big vein inside. Then slowly all the clots will start coming out. Or laparoscopy, incise and remove the clots. Ultimately, otherwise you will end up removing the kidney. So now in this patient, we are going to do DTPS scan and follow up the patient. We'll let you know what happened later. Understood?
Yes, sir.
So suppose in
Yes.
this patient, if we would have done PCN, again there are chances that patient might have bled. So there are always pros and cons of every treatment.
Sir, here
Again?
the matter to be discussed is why there is a bleeding. Number 1.
Yes. Yeah.
And from what place that bleeding has come.
Correct.
So if it is a grossly obstructed, grossly hydronephrotic
And
kidney,
infected.
sudden decompression may cause a bleeding, as like what happened in the over-distended bladder decompression.
Fine.
But here the cortical thickness in preoperative CT scan is not that much thinned out, and
Correct.
it is adequate. So what I feel still is there is extra version of the fluid that may
Ha,
have collected
correct.
subcapsularly and got infected, and it like a fibrotic catching of that kidney has happened down the
Right.
line. या ऐसा लग रहा है क्योंकि कोई कोई सिटी स्कैन में आप रेडियोलॉजिस्ट ने बोला है तो हिमेटोमा है, लेकिन हिमेटोमा जैसा सब लग नहीं रहा है.
Yeah. But still, when we put the drain and everything, and kept it for almost 4 to 5 days, it was only hemorrhagic fluid which was continuously coming. Every day, at least 10, totally 70 cc had come out. And it was like a blood only.
Okay, maybe हो सकता.
Fine. No, but I also thought the same way. It is a fluid only. It
क्योंकि
was
ऐसा
appearing like that only.
नहीं है वो किडनी ब्लीड होने के लिए.
Yes, yes. Fine. Okay. So we discuss the last case. We'll finish in 15 minutes. Bridget, third case.
A 52-year-old female present with a complaint of pain over left flank region since 1 month, burning injuries and increased frequency since 20 days.
You just go ahead. Fatafat.
So patient was asymptomatic before 1 month and then she developed pain over left flank region. Patient pain was colic in nature, sudden onset from left loin to groin, gradually progressing, increase since last 20 days, associated with nausea and vomiting, no specific aggravating factors, and was relieved or taking analgesics. No history of lithoria, hematuria, or no any instrumentation or catheterization, no any bleeding disorder, and patient was not on an anticoagulant therapy or blood transfusions. She was diabetic since 12 years and hypertensive since 15 years. For diabetes, she was taking metformin tablet, 500 milligram BD, and telmisartan, 40 milligram OD. It was controlled. No any allergies. Family history was not significant. Bowel was regular and normal. Blood habits were altered because of increased frequency and burning micturition. Sleep cycle was normal. So, on general examination, patient was conscious, cooperative, well-oriented, time, place, and person. Pulse rate was 76 beats per minute. KFS score was 100, and general examination grossly normal. Abdominal examination was also normal. No any renal anger tenderness or no any
lump palpable. Fine. Okay. So let us start, Rahul. Now what you want to do?
Sir, I would like to do routine laboratory investigations in the form of urine routine microscopy, complete blood count, renal function test, serum electrolyte. Along with it, I would like to do ultrasonography of abdomen pelvis to look for the pathology.
Bridget, show them fast.
So this was urine routine micro which showed 40 to 45% per hypertrophy and occasional red blood cells.
So the next
urine culture suggested of E. coli.
Fine. So what antibiotic do?
Sir, according to the culture sensitivity, I would like to give meropenem as she is sensitive for the meropenem, as well as her WBC counts were high. So I would go for higher antibiotic.
What is the WBC count?
Sir, 28,000 counts. So, sir, meropenem would be the better choice with sir, control of sugar also.
Okay, fine. Bye. Show the ultrasonography. Quick. Swapnil, now you read it. Just
Yes,
important features. Tell us. What is the right side? What is the left side?
The left side kidney, there appears dilatation of the PC system with loss of CMD, splitting of the central sinus fat is seen. Right side looks normal, sir.
Normal. Anand, do you think it is right side is normal?
No, so there's a dilatation.
Right side is
Dilatation of this system. Right side also.
Dilatation or total acoustic shadow? Right hand side, right bottom, you just see. Right hand side, bottom,
Yes, sir, yes, there is a shadow. Yeah.
the huge
Staghorn calculus.
acoustic. Yes, so right, left side is obstructive system, right side is second calculus. So now what you want to do? What you want to do?
Sir,
Anand, this is the patient. Now what you want to do? Just see, na, beta.
Thinking, why you are thinking too much? You just ask the report of sonography, confirm it on that it is a Staghorn stone and opposite side, whatever the pathology you are suspecting. And as per that pathology, for planning the next procedure, only investigation remaining is CT scan. Anything else you want to do, you don't want to do anything else. So tell it immediately.
Yeah, culture and you want when you know that this patient will require the intervention. So total workup. So you say culture sensitivity, I like to do CT scan and along with that total workup. Correct?
CTIV.
Okay, fine. Show CTIV.
So this was the X-ray.
Okay, fine. Rahul,
Yes, sir. This is
tell me fast. Yeah, tell me.
sir. This is X-ray of abdomen. Suggest bony landmark. It is not well centralized, well exposed, as source shadow on right side is not visible. Bony shadows appears normal, and slightly scoliosis in the spine is noted. And sir, soft tissue shadow looks normal. Bowel is not very well prepared, and on right side there is a radio opaque shadow seen in the renal area, suggestive of the Staghorn calculi. On left side there is upper ureteric calculi located in the region of L3, lower border of L3 vertebra, suggestive of the right upper ureteric calculus.
Left upper ureteric.
Sorry, left upper
Left.
ureteric calculus.
Okay, fine. CT scan, just to Bridget, CT scan. Okay, basically it is showing good function on both the sides. So there is a left sided partially obstructed system and right side Staghorn calculus. Correct?
Yes.
The count is 28,000. Now what you want to do?
Sir,
I would like to do left URS first, sir, and after when the patient is stabilized, I will go for right PCNS.
Okay. See, we first of all like to stabilize the patient. We give antibiotics, but still the count has remained from 28, it came to 24,000. But otherwise, patient had no other symptoms. Hemodynamically, otherwise everything was normal. So now what you want to do? Let us start with Rahul. Rahul, I will ask you a question. You listen. You want to do only left-sided ureterinoscopy, or you want to do something else?
Sir, I would like to do bilateral degestenting, sir.
Okay. My question is, do you think that right-sided degestenting will drain it?
Sir,
Rahul,
sir,
think what is his or her first complaint? Why she has come or he has come to you? Number one.
Yes.
Number two, if you are planning a bilateral degestenting, is that degestant is going to drain on right side? Number three, function. If CT scan assess the function, cortical thickness, symptomatic side, better functioning side, more curative procedure, plan more curative procedure.
non-symptomatic side, but obstructed, plan something like a obstruction. So ये सब दिमाग में सोचना है और फिर आंसर देना है.
Sir, but a patient, in spite of giving higher antibiotic, still counts are high, and
कैसे
sir,
कम हो गए? How it will go down? That one side it is obstructed, partial or complete. Another side is stagnant. So there is a source of infection on both the sides. So why you are expecting by giving antibiotic it will come down?
so sir, left side degescenting, and for right side,
What is the complaint of patient?
sir, right side flank pain.
Right side flank pain. So right side is symptomatic.
Left side flank pain.
So left side flank pain. So left side is symptomatic. Left upper ureteric stone. No too much gross hydronephrosis. Ultrasound if it is suggestive of internal echoes, no internal echoes. Cortical thickness maintain. PT function is there.
Yes.
So that side more curative procedure for remove the symptoms as well as to treat the disease. On right side, asymptomatic, but functioning kidney. Okay. So उसको
Yes,
ड्रेन
sir.
करना है नहीं करना है, स्टेंट करेंगे नहीं करेंगे, मैटर ऑफ क्वेश्चन है. क्योंकि उसको अगर आप भी स्टेंट करके रखा और तुम्हारे स्टेंट की वजह से इन्फेक्ट हो गया
Infect हुआ
तो
तो
आगे का
फिर से
प्रॉब्लम हो जाएगा. So
Fine.
right side deobstruction plus minus if you can tell in exam, but left side ureteroscopy, stone removal जो भी प्रोसीजर की वे से करना है, फ्लेक्सिबल यूज करो, सेमी रिजिड करो, जो करना है करो, वो लेफ्ट साइड का करना है. तो सेमी रिजिड अपर यूरेटर के लिए बोलना है क्या तो नहीं बोलना है. और स्टोन ऊपर चला गया तो सेमी रिजिड ureteroscopy is not made for upper ureteric stone. So what you have to tell in exam, we don't have flexible ureteroscope, we will try with semi-rigid ureteroscope. If stone went up, we will place the DJ. Then reassess Huntsville unit कितना है उसके हिसाब से हम बाद में उसको lithotripsy देंगे. नए Huntsville unit ज्यादा है तो उसको मैंने चैनल करके निकाल दी. ये इंस्टीट्यूट के हिसाब से बोलना है. फ्लेक्सिबल है तो बोलना है फ्लेक्सिबल RIRS कर दूंगा. जहाँ पे भी गया वहां पे जाऊंगा, उसका पाउडर बना दूंगा, स्टेन डाल दूंगा. क्योंकि वो साइड सिम्टोमेटिक है, वो साइड मेरे लिए इंपॉर्टेंट है, फंक्शनिंग भी है वो. एग्जैक्टली वो साइड को सिक्योर करते समय राइट साइड को भी कुछ सिक्योर करने की जरूरत है कि नहीं है. अगर सिम्टम्स है राइट साइड को, फंक्शन डिटोरेट हो रहा है, हाइड्रोनेफ्रोसिस बहुत ज्यादा, हाइड्रोनेफ्रोसिस बहुत ज्यादा नहीं है, होल किडनी इज इन्वॉल्व्ड बाय स्टोन, ऑल कैलसिस आर फिल्ड विद स्टोन, एज अर्ली एज पॉसिबल उसको भी करना है. So I don't want to make the system get infected by myself by placing the stent or patient, as there is no gross hydronephrosis भी नहीं है ड्रेन करने के लिए. patient करना है, डिजेस्टेंट करना है तो क्यों करना है? What is the reason? So for to be obstructed. So if it is obstructed, then there should be a hydronephrosis. There should be a hydronephrosis. If there is no hydronephrosis, then why want to place the digestant and infect the system? So my priority will be on left side. जो भी बोलना है ना वो क्लियर कट बोलना है. एग्जामिनर को अगर उसको पसंद नहीं है, दो बार उस क्रॉस कर रहा है तो उसको एक्सेप्ट कर देना.
Fine. So as sir said very rightly, you can say left side ureteroscopy first you will do, you will wait. But what we thought that right side is so much impacted stone and it is appearing absolutely infected stone, as you can see even in the X-ray. So we thought that let us make little space and we can divide the case into two parts. So we did left ureteroscopy, which was over, okay, within 15 to 20 minutes. The urine was quite clear, means there was no infected urine. So we decided to do a PCNL on the right side, clear the center part so that it can drain very nicely. So we did two punctures and removed the middle calyx, pelvis and surrounding area. Okay. Now, Brijesh, tell them next day what happened.
Sir, एग्जाम में वन सिटिंग बायलैटरल सर्जरी ये सिचुएशन में नहीं बोलना है.
नहीं व्हाट वी
प्रैक्टिकली सर ने किया है वो अलग बात है. एग्जाम में लेफ्ट यूरेट्रोस्कोपी प्लस राइट साइड का डीजे बोलना है तो डीजे बोल दो. कोई प्रॉब्लम नहीं, that can be accepted.
So in exam, what Dr. Gite said, just said left-sided obstructed system. So I will manage the first left side. Okay, but this is what we did. By show them what happened the next day.
So
The next day,
post of that is her hemoglobin was 9.8 and WBC count raised to 51, and serum create became 1.9. CRP was 50.
okay. So now again we waited for 4 to 5 days. Then the she was absolutely fine. Hemodynamically, no fever, everything was okay. We waited for 4 to 5 days. Everything improved. WBC count came to, what was the last WBC count before surgery? 24,000. Okay, creatinine had decreased. So what we decided to finish off the PCNS because already 4 to 5 days, again higher antibiotic had gone. So we did PCNL, cleared the full system. Post-operatively, show us what happened. Bridget, the last report. So next day, hemoglobin 9.7, count has decreased. Platelets are normal, creatinine is 1, patient is absolutely normal. 2 days later, the count was 9,000. We removed everything and we have discharged the patient. Okay, so in this case, the right thing will be to first do only left side and then tackle the right side. But in this case, we were lucky that even though the count had increased so much, patient never went into septicemia or urosepsis. Probably, we had covered patient with a good antibiotic. And we
And kidneys drained by both ways, by PCN as well as DJ.
Correct. Okay, so all these 3 cases are totally different. In exam, now you know how to answer and what to answer. Any question, please ask us before we stop our discussion.
देखो in exam,
आपको
anything which suggests towards active infection inside the system, don't tell curative procedure.
Yeah.
Yes, sir.
Anything, raised TLC, fever, local tenderness, raised creatinine, gross hydronephrosis, anything combination permutation में कुछ भी अगर मिल गया तो डिफेंसिव मोड पे जाना है, मैं ऑब्स्ट्रक्ट कर दूंगा, वेट करूंगा, फिर करूंगा. लेट एग्जामिनर से कि भाई यू आर वेरी सेफ टू द पेशेंट. देखो एक्सपीरियंस एंड थियरी ये बहुत डिफरेंट चीजें है.
यस,
क्योंकि सर ने हजारों पीसीएनएल कितने हजार किए सर को भी शायद याद नहीं होगा, इतने पीसीएनएल हो गए होंगे, तो सर को अंदाजा आता है कौन से पेशेंट में कितना कब करना है नहीं करना है, लेकिन एग्जाम में ऐसा नहीं बोलना है.
Yes.
Okay, so see, these 4 cases we have kept with the complication. So all of you have got now idea what to do, when to do, and what to answer in exam. Okay.
Yes.
If any one of you have got any question, please ask us now, or you can put it on a group. We will answer. Fine. Even related to these 4 cases, with the contact to these 4 cases, you can ask.
So that second case where the patient had a 15 mm large impacted VUG cal with gross hydroureter nephrosis. So when do we consider doing the functions?
Actually, first time only after 24-48 hours. Ideally, we should have done DTPA renal scan when such a big gross hematoma is. And if it is really compressing, that it is compromised, function is compromised, I feel that we should have gone inside and removed the hematoma.
Yeah, exactly.
Sir, I mean before the URS.
If you tell in exam, patient had a moderate to severe hydroureter nephrosis, and I want to do a DTPA scan prior doing any intervention for to know the basic local baseline function. It is okay. Nobody will blame you in this patient also. Number two,
Yes.
if you tell after first case if it is not draining by placing the PCN, then I will go inside considering the compression and decompress the kidney like a decortication. That answer also will get accepted. Number three, and now we are planning to do a DTP scan for how much function is remained after having a long standing compression by the whatever the pathology there. So that the function getting a amount of function to preserve the kidney chances are slightly less. What I feel, we will see what will be the report. Here, doing a DTP scan is to know the exact remaining function of that kidney.
Yes.
Yes.
Okay. So DTPS scan should have been done earlier also. And if it is showing a good function, then you can repeat it. And if you feel that
Sir,
something is wrong, then go inside and remove the clot.
Yes.
Okay.
Sir,
And
in this last case,
yeah. So second, your question is that before doing surgery, ureterinoscopy, now this kidney was functioning was good, his parenchyma was good, and there was no gross hydronephrosis, not thinning of the parenchyma, and it was CT scan was showing the function. So there is no need to do DTPA renal scan. Every obstructed system you don't do. If there is a severe hydronephrosis, like the first case, severe hydronephrosis, function is not, it is a delayed function, and you are expecting that this function is less than 15%, and this is infected system, you want to do nephrectomy rather than to do any other surgery, then you do DTPA.
Yes.
Okay, your answer is, your question is answered?
Yes, sir. Thank you.
Okay, fine. Next.
Sir, in this last case, sir, left side obstruction only with degestant can be done, and after that we can proceed to right side. Is it wise decision?
That bilateral degestanting can be answered, but if I am examiner, I will ask you why you don't want to remove that stone on left side.
Sir, because a patient had a TLC count high, and that's why I am first going for the
You are
deobstruction.
worried that patient may went
Yeah,
into the
patient went to the
sepsis.
urosepsis. That's why.
See, with the 28,000 count also, patient was absolutely fine. Everything was okay. And this stone is very small and it is not totally obstructive. That means the left system is draining. Okay. And you can finish that. You see, the digestion, if it is going to take 15 minutes, but if you go inside and if you see the stone and if you are able to remove in another 5 minutes, do you think that by putting a digestion you are wiser? But like in the second case, first case, such a
No, sir,
big
for
stone.
just for exam answer.
सर एग्जाम में 28,000 अगर TLC है और वो साइड सिम्टोमेटिक है और लोकल टेंडरनेस है और उसने अगर स्टेन बोला है तो people will accept.
Perfect. Exactly. But here,
What
patient
Rahul
has
has
already
said, they will accept. Don't worry.
Yeah,
Whatever
they
you
will
are
accept.
going to tell, you have to defend it.
You can always say, okay, sir, but right-sided degescenting will not help much.
Agreed.
Left side, definitely.
Okay.
So you can say, okay, sir, in this case, first of all, like to put degescent, or you can, drain the system. Okay, you will not be wrong. Fine.
Yes.
Okay, Rahul.
yes, sir. Yes.
Good.
Yes, sir.
Okay. Thank you. So next time we'll let you know what we are now. Again, our series will start. Okay.
Yes, sir. Good night.
Yes.
Good night,
Good night.
Gita
Good
sir.
night.
Good night,
Good night,
Gaurang
sir.
sir.
Thank you, sir.
Good
Yes,
night
Hiren,
to
good
all.
night.
Everybody,
Thank you,
bye
sir.
bye.
Thank you, sir.
Bye.
Thank
We
you, sir.
miss Maheshwari this time.
Yes.
He is in transit.
Yeah. Okay. Good night.
Okay, sir. Good night.
Rahul sir.
Thank you, sir.
Rahul sir.
Yes, sir.
Yeah.
Yes.
प्लीज एंड द सेशन एक्चुअली मैं ट्रेन में था तो आप होस्ट बन गए हो end session कर
Okay,
दीजिए
I
सर.
will end the session. Okay, sir.
हाँ हाँ.
Yes, sir.
Don't
Thank
leave.
you.
End the session, huh? End the
Yes, sir.
session.